I think I might have figured it out. Okay, we're good now. All right, great. Had some technical difficulties there, but I am here with Fredrick Dombrowski. Do you go by Fred, Dr. Dombrowski?
Oh gosh, like just Fred is fine. Dr.
Fred.
Dombrowski sounds weird, yeah.
Okay, sounds good. Well, this is part of our Facebook Live series called IMHCA Talks, where we interview different mental health professionals in and out of the state of Iowa, just about topics that are relevant to mental health counselors. So my name is Sean Abramowitz, and I'm a representative of the IMHCA board, and I'm a student at Drake University working toward my LMHC. Before I introduce Fred, I just want to put in some plugs for what's going on at IMHCA right now. We have our annual conference coming up. That's April 20th to 22nd, and the registration is open now. You can find that on our website, and also on our Facebook page. You can find a link to that too. Next month, we're going to have another IMHCA Talks where I'm going to be talking with Amanda Hardy, who is an LMHC here in Iowa, and she's going to talk about perinatal mental health counseling. But I wanted to get to Fred. So Fred is the president-elect of the American Mental Health Counselors Association. We were talking a little bit before we got on, and Fred is saying he has some imposter syndrome around that, and it doesn't really feel real for him yet, but we're really excited to have you. Have someone who's such a big deal and so important. Fred is also the chair of the University of Bridgeport's Clinical Mental Health Counseling Program. That's a university in Connecticut. And he specializes in CBT, DBT, transgender mental health, co-occurring disorders, and telehealth, and probably a bunch of other stuff too that I missed. So he's a regular contributor to the Advocate magazine, just a national advocate for the LGBTQ community. And, you know, I'm really interested in talking about trans mental health counseling with you. But before we get into that, I know that you had an announcement about a book that you just got published, and you had a little surprise for us. So I was wondering if you could tell us about that.
Yeah, absolutely. And I really appreciate that. This is all about like timing. So like, please forgive me for sounding tacky. Myself and two other authors, Dr. Tricia Chandler and Dr. Tara Matthews, we've been working on a book on co-occurring disorders for the last like 2.5 years. It finally got submitted, and it looks like it's published, and it's going to be out on March 25th. So if anyone is interested in getting a free copy of the book, if you could just feel free to send Sean maybe your email, and a random person who will send Sean maybe your email or send him a message on the IMHCA website will win a free copy of the book, and we'll be happy to send it out to you. We're just happy to get any feedback, but it's a good book, specifically as most co-occurring texts are not written by counselors. So this was written specifically by counselors for counselors about specifically integrating treatment for individuals living with both mental health and substance use diagnoses.
That's great. And I should say, I think the best way to get in contact about that, if you want to be entered into our drawing for the free book, would be to send a message to the Iowa Mental Health Counselors Association Facebook page. I think that would be the best way to do it here. But yeah, before we get into co-occurring disorders, because you literally wrote the book on it, so I'm sure you have a lot to say about it. But I wanted to start with transgender mental health therapy, and I guess we can talk about like the how that happens. But first, I want to know more about you and why this has been something that's so important to you, something that you've written about and presented about. What made you such a strong advocate for the LGBTQ community and for trans people in general?
So yeah, absolutely. So like, and just one quick thing. I am a department chair at the University of Bridgeport. I'm a department chair for the general education social sciences undergrad, although I teach full time for the clinical mental health counseling program.
Okay.
So not that department chair yet. So, but I have a great boss. Everyone's very great there.
Mhm.
But it's interesting when people ask me how I got into specializing in transgender clinical mental health, and that was something I never really like had passion for. And so when I was in undergrad, I started my career in 1999 when I was getting my bachelor's degree, working with individuals at a residential facility who were living with severe and pervasive mental illness. It was a wonderful job. And as the job progressed, I was made more aware of my limitations because I only had a bachelor's degree. And as it was a residential facility, we were working more on developing activities of daily living, maintaining medication management, and helping individuals to stay out of the hospital. It's a wonderful program. And it really sparked my interest in actually doing mental health counseling. So I felt really comfortable being exposed to like various diagnoses. But when I was getting my master's degree, I had to present for my abnormal psych class on something that I've never worked with before. And I had never worked with anyone who was diagnosed back at that time in the DSM-4 with gender identity disorder, now gender dysphoria. And I was so lucky that a fellow student in the class knew someone who was willing to sit down with me and talk with me and actually like go to the class to talk about it. And so I'd never met anyone who identified as trans. And I met with this woman in Buffalo, where I'm originally from. And she was so lovely. And knowing now, knowing now, unfortunately, back then I asked all the wrong, bad questions that I shouldn't have asked. But she was so incredibly gracious. She saw that I was coming from a place of like ignorance while also trying to understand it and not trying to judge by any means, just trying to like get a sense. And because I'm a white heterosexual cisgender and I'm a born again Christian male. And so these are all things which would feel kind of disconnected to me. So like for me, I've never for me, my gender identity was assigned at birth. And hearing her talk about how she made sense out of her gender identity, her experiences, her exploration, it was like a wonderful conversation. And it really hit home like the diagnostic criteria. So, and what's difficult about like the DSM is we don't want to make people who want to transition, we don't want to say, hey, listen, you have a diagnosis, this is something bad. Within that said, though, the focus is on the dysphoria that is caused when someone is not who they feel that they should be. So as I've furthered my career, unfortunately, people often made assumptions about my sexuality, and they assumed I was gay, although I was like, I never really talked about like my background, and I never tell my patients about my gender identity or my sexual identity, or I never tell them about my religious affiliation. I'm like pretty strict with that stuff. So as people made assumptions about my sexuality, they would say, oh, well, you're gay, you could work with someone who's trans. And that, now knowing what I know, is actually extremely offensive, because when we say like the LGBTQIA plus community, it's actually the LGBTQIA plus communities. So when I left Buffalo, I had LGB experience, some T experience, and I got a job working at Our Collective Mental Health in New York City, which was a primary LGBT clinic. And I was supervised by Dr. Michael DeMarco, who was a sexologist. And he was such a wonderful, caring, like supervisor. And as we worked primarily with like LGBT like issues, I was very like open with him, but he was like such a good mentor, such a good support. But every time I got in my own way, like in regards to something that didn't make sense to me, he was able to utilize, he did REBT, which is very, similar to CBT, and that's my backbone, but we were able to use these skills to get me out of my own way. So from that, I then became a director for the Gateway program at the Westchester Medical Center, where we provided LGBT specific services with a heavy emphasis on trans work. And from there, like diving headfirst into that and getting very familiar with trans work, doing a ton of ongoing education. This sounds weird, but it was so much fun. It was so much fun working with people and having people do the work to find themselves. It was so much fun, like having people feel comfortable in their skin. It was, and so within that, like there's like various ways of going about doing it, but I am so passionate about this because I think there's a lot of misinformation and assumptions when it comes to working with trans people. And also I respect there's a lot of advocacy to support members of the LGBTQIA plus communities, and instances where like even we have to still maintain our role as a counselor. We don't want to impose our thoughts on the client. So it was so much fun and it was so dynamic. And what made it really comfortable for me was reading the WPATH Standards of Care, and that stands for the World Professional Association for Transgender Health. And with my supervisor, Dr. Michael DeMarco, that's the first thing I did. I made sure I read that book like backwards and forwards, and it's not very long, but it outlines everyone's role, like every clinician's role when working with someone who is in transition. And it also discusses what our expectations are. And within that, the WPATH Standards of Care discuss our role is engaging in gender exploration. So I didn't have to tell anyone they should or shouldn't transition. I didn't have to argue with them. I didn't have to do anything. All we had to do was just good old fashioned exploration. And that was so much fun because I got to like use CBT with that, but also ask some really fun questions that I never considered before. Like, what does it mean to make someone a man? What does it mean to be a woman? Does the way you dress make you that way? And whenever I do a presentation, I usually give this analogy that, I knock on wood, God forbid, if I get into a car accident and my penis gets chopped off, does that make me any less of a man? And everyone's like, no, that doesn't make you less of a man. And well, how do we respond then to trans men who may have been born biologically XX, who identify as men? So as I got into it, it became very fun, but I was exposed to very good people who were trying to work with trans and LGBTQIA plus communities who didn't know about the WPATH Standards of Care and like did some things like out of order. So I'm very passionate specifically about that because I've really enjoyed the work. Like I enjoyed talking and educating clinicians about it because I've worked with, in Westchester, outside of New York City, you would figure it's a very liberal area. But I would get calls from mental health clinics like weekly saying, we have a trans patient here. We refuse to work with them. You're the expert. We're going to send them to you. And I'm like, well, it's a 3-month waiting list. You have to work with them in the meantime. They'd be like, well, we can't work with them. I'm like, well, you're going to have to. And so that was offensive to me. Like people like mental health clinicians who would say they would be supportive of trans people while also being afraid to work with trans people. And now there's such a need for mental health that we don't have the luxury of waiting lists anymore. And clinicians, if we don't have the experience, we have to go get the experience. So for the trans community, they were so underserved and in some ways, I don't want to say inappropriately served, but they were so underserved. And when you actually do the work, adhere to the WPATH Standards of Care, and there's a lot of people who have like appropriate complaints about the WPATH Standards of Care. I respect that, but I do appreciate, at least right now, it's a guideline for us to follow. And it made everything so much easier for me. That's a very long answer. I don't know if I got to what you were asking for, but
I think so. And I guess I wanted to call attention to the fact that you are a cis heterosexual man, and I am too, and we're talking about trans people, and I'm wondering, I know that's that's something that's a sensitivity to have when within that community, or with any community that you're not a part of. I'm wondering if you could speak to that and what your experience is with counseling people who are trans while not having that experience for yourself?
Yeah, that's an absolute great question. And I was so lucky to have my supervisor. I had Dr. Michael DeMarco, because when I first started working with trans people, what was very helpful was when we conceptualize trans populations, even within the trans community, there's a ton of variance. And there's, so not every person who has a gender identity, either male, female, boy, girl, outside of the binary, is going to be the same. So within that, although even if I were trans, my identity would be unique to me. That doesn't mean that I would share the same identity with the individual I'm working with. And when that was kind of posed to me, I'm like, oh my gosh, you're right. And then after I met like dozens of trans people with various identities, it became clear to me that my identity, what mattered more than my identity, was using an approach of cultural humility and being extremely invested in the progress of the individual. So within that, I mean, don't get me wrong, like as a cis, like heterosexual white guy, there were tons of things I was presented with that made absolutely no sense to me when I first heard them. And I really respect my supervisor because he was able to walk me through it, like, and without like shame, without like putting me down. But I walked through it, I'm like, oh yeah, I got to that conclusion, like, all right, my assumption wasn't helpful. So, but he did it like so delicately. And it was, so within that, there is a lot to learn, but that I really value like the cultural humility aspect. And I really try to encourage everyone to show that in every instance. It's okay if we're not the experts on everything, but if the individual knows that we're 100% committed to working with them and we're going to do everything we can to help them obtain their goal, I think that does help.
At the risk of having you embarrass yourself or implicate yourself, I'm wondering what some of those assumptions that you now cringe at were. Because I'm guessing that maybe some people listening maybe might carry some of those same assumptions.
Yeah, absolutely. So like, and this is stated in the WPATH standards of care. And this is stuff I heard when I was doing my education, because I've done tons of continuing education. And if anyone listening would like, I'm happy to send you a copy of the WPATH standards of care, as well as there's like a National Center for LGBT training. I just forgot the name of it, but they do free continuing education units. They're an awesome place. And I've done these trainings before, and I knew this stuff, but when you see it in real life, there's a difference between reading it and then actually seeing it. So one thing I really struggled with in the beginning was believing that sexuality and gender identity were connected.
Mm.
So, and they're not. And so people are going to be attracted to whoever they're attracted to, regardless of what their gender identity is. And people are going to do whatever they can to feel comfortable with their gender identity, regardless of their sexual attraction. So when people were transitioning, I would often assume sexual attraction based on how the individual was transitioning. I kind of believe that these things were fixed and would be connected to each other. And then after like working with several trans people and hearing their experiences with sexuality, how it was disconnected, how people they weren't necessarily attracted to, eventually they became attracted to, it was a lot of fun, but it broke that off. And so that was something I really struggled with in the beginning, because I believe that sexuality and gender identity were the same, and they're not. And I think that's one of my critiques of, like, saying the LGBTQIA plus community, because each individual group within that has their own needs. Mm-hmm. So when I conceptualize someone who has same-sex attraction or same gender attraction versus people that don't, those are the term we've been using for a couple of years has been more affectional identities. Affectional meaning affectionate, whereas gender identity is a separate thing. And I like that conceptualization, as well as working with people who are intersex, like the I in LGBTQIA+, intersex, like the individual was born with a mix of XX and XY chromosomes. So what does that have to do with their sexuality? So, but they get lumped in with her, and the needs for individuals who are intersex are entirely unique among LGBT communities. So the more I learned about these communities and the needs, the more fascinating, the more fun it became, the more I worked with clients, the more I watched them the more I watched people find um, lives that they felt more connected to was just a lot of fun. When I became a counselor, I wanted to help people. And I don't think it's necessarily me that's helping. I think it's the client who's doing the steps, but it's just a lot of fun when you see it work.
You spoke a little earlier to the diagnosis of gender dysphoria, and I think what you said was you didn't want that diagnosis to tell people that there was something wrong with them. Is that kind of what you? Yeah, okay, and
Yeah.
I'm wondering if you could talk more to that diagnosis. I know there are issues with, at least in Iowa, from my understanding, in order to, if people want to have gender affirming surgery, they need to, I, I'm not sure if it's a law or if it's insurance company regulations, but you need to have that diagnosis in order to get approved for gender affirming surgery. I don't know if it's like that other places in the country, but I was wondering if you could speak to that.
Yeah, that's a great question. So, and that's where like there's a dialectic happening, like two opposing truths. So usually when I would first meet someone during an intake, and if they told me that they were here to see me because of issues related to gender, I'd be very upfront with them discussing the diagnosis, and I would review with them the diagnosis in the DSM, and I would also review with them the way the WPATH standards of care conceptualize the diagnosis. So through the DSM, the symptoms in the DSM are pretty specific, but with the WPATH standards of care, the way they conceptualize it, the dysphoria, meaning the lack of living an authentic life, any anxiety or stress caused by not being the person that you're meant to be, disconnection with friends, family, that is the diagnosable aspect. So when we conceptualize gender dysphoria, we don't conceptualize someone not feeling or not having their gender being assigned at their sex at birth. That's not the diagnosable aspect. It's the discomfort that comes with it. So I try to tell people like about both of those aspects, but I do tell them that in order for me to have them linked with adjunct services such as hormone replacement therapy, any potential surgeries, name change, documentation change, that diagnosis does need to be on there. And when I explain to them like how and why, usually it's been okay. Like I haven't had any clients who were offended by it. But when I explain to them, like, I conceptualize it more from the WPATH standards of care, that the harm that you're enduring during your life is more of a diagnosable thing. And so when I describe it that way, usually people would agree with me.
And how do you feel about that needing the diagnosis for the? I know that not everybody who's transgender wants to get surgery, but I'm wondering if you see any barriers in that regard.
So I feel kind of conflicted by it because I don't like the idea. I mean, like, I just don't like the idea of, I don't have a problem with diagnosis. I don't have a problem with diagnosing it. Like, I don't think there's anything wrong with identifying an area that could be fixed. If I have a broken arm, it's going to be a diagnosis of a fractured whatever. So the diagnosis within itself isn't particularly what bothers me. It's more the stigma that comes along with it, especially with mental health. With that said, though, a benefit of it, though, is when you link someone up for treatment and you put that information in there, like the other people that you're linking them up with, when you actually see that and see that information, then the individual can adjust what they're doing. And so usually what I try to do is when I'm working with someone who's trans, if I send them over to an endocrinologist, I'll have the individual sign a consent form, and I will call the endocrinologist up front and say, listen, I have a trans patient. The patient's born biologically male and they are transitioning to female. I would really appreciate if your staff used her name and her preferred pronouns. And saying that, and also touching base. So having that on there, people have an opportunity to prepare and make the environment more affirming. So there are benefits, although I feel conflicted about it because I just don't like the stigma that's associated with the diagnosis.
What other steps do you take to advocate for people who you're counseling? I heard you say that you call ahead to other providers and talk about pronouns and names that maybe aren't necessarily legal names or legal names yet. I'm wondering if there are other ways that you advocate in a network of providers.
Absolutely. So like what I like to do, and I've been doing this for years, but I will go to like various community services and provide like free education and training about working with trans patients. And so me being from Buffalo, I was back in Buffalo a couple of weeks ago, and I presented at like 2 agencies specific about like transgender stuff, and also given them the basic information of the WPATH standards of care. And within that, like, I mean, I respect people's personal backgrounds. I respect people's personal feelings. I respect their belief system. But what I try to encourage people to do is just get out of their own way, though, to make an inclusive environment for an individual to be able to explore and find themselves. And everyone can usually agree with that. So also within that, I have ongoing discussions about when we experience countertransference or negative feelings towards someone about their transition and how we can then manage that. So I do like, I mean, I'll do like 15, maybe a year, a training specifically about transgender health. In addition to that, I'm also, I still do some contracting with the state of Connecticut specifically for their forensic system, for the forensic clients who identify as trans, and advocate for them. I've been very lucky to help adjust policy on the state level, specifically in regards to the work for the state hospitals and for the forensic system. So that has been a lot of fun to do. So like there's different ways of advocating, but I appreciate having that opportunity for that change, and especially in pretty difficult environments like a forensic hospital.
And you spoke, I wanted to go back. You spoke to the WPATH standards of care, and I was wondering if you could give us some nuggets from that. Like what parts of that standard of care do you think are the most important, or most that counselors need to know about the most?
Yeah, absolutely. So like, so as a director for the Gateway program, I had tons of people who may identify as gay or lesbian or bisexual themselves, who really wanted to work at the program, and they were so incredibly passionate about working with the LGBTQIA plus communities. And so I would ask them, do you have LGBT experience? Everyone said yes. Then when they sat down in front of a trans person, they would say, oh my God, I can't do this. I've never worked with a trans person. And I would meet with them and I said, well, you said you had LGBT experience. And they said, I do. And then I would say, well, what about the T? And they're like, oh. So we say those letters so quickly that people get lumped in with each other, where the T, the trans, is a unique experience. Within the WPATH standards of care, what I do appreciate about it is it adheres to like recommendations that are there for counselors. So according to like our code of ethics, we're not allowed to impose our beliefs on people, and we're not allowed to encourage people to do anything. We don't encourage people to do anything. Rather, we listen to what the individual's goal is, and we use tools that are theoretical and evidence-based, which help the individual to get there. So with WPATH, specifically for the role of the counselor, like I was like thinking to myself, oh my gosh, how do I talk this person into transitioning or out of transition, or how do we manage this? And they described specifically our role when we engage in gender exploration. And what I liked, it said like licensed clinicians are, if they're licensed, they're expected to have the skills to be able to navigate various other aspects of the individual's life. Within that, though, the focus in on gender transition and what does that look like? And they don't get too much in what it looks like, but as I've done continuing education, what it looks like is having an individual who might feel disconnected from themselves, having instances where they might try on different clothes or try on a different name. And they have the opportunity to adjust and make adjustments as they go to find a way that would make them feel comfortable. And we continue to explore that. And the way they state it is eloquent. And then the additional education I've done, the Fenway Institute, that's at the Fenway Institute. If you check out the Fenway Institute, you can get tons of free continuing education, but doing additional trainings within that, seeing, just asking those questions, like asking people like, if there were no words male or female and the world was able to respect you regardless of what you look like, how would you be? And how would you be in the most comfortable form of you? And having that discussion. And so that's been really good. Also, when they talk about linkage with other services, they have really good discussion about like linking with hormone replacement therapy, because as mental health clinicians, we have to be aware of how hormones impact people. So I don't conceptualize hormones as drugs, but they technically are. And in addition, like when any one of us like goes through puberty, we experience various changes in hormones and difference in emotions, aggression, hypersensitivity, all those things that kind of come with it. So having that information, especially when living with someone who has a co-occurring like depressive disorder or anxiety disorder, or someone living with bipolar disorder. And in addition, what I really liked is how the WPATH standards of care explain, like, it doesn't matter what your mental health diagnosis is. You can be diagnosed with anything: schizophrenia, borderline personality disorder, schizoaffective disorder. And if you meet criteria for gender dysphoria and you want to transition, it's our job. So when I conceptualize it that way, that's like what really like made it like different. Everyone asks, well, what if the person's living with schizophrenia? Are they allowed to transition? Yeah, we want to do some exploration. We want to identify what's impacting. Like, I did work with this one guy who he was in his 50s, never had any experience in his life where he felt disconnected or uncomfortable with his body. He enjoyed being a man, always felt like he was a man. While he was hospitalized, though, he said the voices were telling him that he needs to transition. So therefore he wanted to transition. But as we go through like the standards, and I said, listen, we're here to help you. We can't link you up with someone right now. Let's see how your symptoms are reacting to medications, and we'll get you with some ongoing treatment to explore. So that was like the only person out of all the other diagnoses I've worked with, that was the only person I was thinking, all right, let's put the brakes on this just a little bit. But the WPATH does an excellent job of explaining that. They also explain what the doctor's roles are. They explain like the different parts of surgeries, what's needed within the surgeries, the clinician's job in the surgeries. So technically, from WPATH standards of care, you can see someone once and then link them up with hormone replacement therapy. But what they recommend is if the individual does get linked up with hormone replacement therapy, that they continue to have ongoing support through counseling, because life changes. And so everything they said just made sense to me. It made sense. So I know people, I've read critiques about the standards of care where people are concerned about the evidence that they cite. And I can respect the concerns that people have with that. With that said, though, I still think it's a valid tool that just helps us plan. So one of the dirty words when we talk about working with transgender people, and if I talk about this, like in some, I've had people get mad at me when I talk about detransition, where there are people who do detransition, they'll transition and they'll transition back. And people get mad at me when I bring that up because they feel that I'm undermining the gender transition, and I'm absolutely not. So just because CBT doesn't work with one person doesn't mean it's not effective with another person. With the individuals I worked with who detransitioned, though, they never had that opportunity to explore their identity. They just jumped into a different gender without having that opportunity to explore. So I'm very lucky that none of the patients I worked with over the years have detransitioned, because I was so serious with adhering to the WPATH standards of care of gender exploration. Because when the client explores their gender, the client finds himself. It just made so much sense to me.
So it sounds like you you've identified ways in which you feel like counseling is integral to people who are going through transitions, gender affirming surgery or hormone replacement therapy. That counseling is very important to that, and it's not just a medical thing. Am I hearing that correctly?
Yes, yeah, absolutely. And a lot of clients, when they would see me, they would view me as a gatekeeper. Like I was a step just to get them linked in with other stuff. And therefore, I would have clients who weren't honest with me. And that didn't mean that they didn't trust me, but they were worried if they talked about being sad or being depressed, that they were worried that that would prevent them from being linked up with treatment. And so we had to do some education about that because that's a limitation. So if we're working with someone who's living with real severe depression and they're not showering and they're not taking care of themselves, and if they want to get some pretty intensive surgeries, that lack of self-care with a surgery like that leads to greater risk of infection and death. So we would definitely, I would tell the person up front, listen, this is your goal. We're here to work on that goal. What I'm seeing is a potential danger. How can we work on improving this over in this aspect? So then when you get to this part, it's the perfect fit for you. And we have those conversations, and counseling is integral, absolutely.
I've heard, so I hear you saying that counselors are the gatekeepers, and you've talked about ways that can be a positive thing, and it can be helpful, like in the example with depression, with somebody who needs to be able to effectively recover from surgery and needs to be able to maintain their hygiene. Are there ways that you've witnessed that this gatekeeping can be negative and create barriers, or things that counselors need to look out for? Maybe some things that we wouldn't think of necessarily.
Oh, absolutely, yes. And I do apologize if I came out as saying that gatekeeping was positive in this. I absolutely don't think that it's positive. I think that it just, like, within itself, there's a negative connotation, which creates a barrier for the patient to have like full treatment. So that belief, so we're not gatekeepers. We're really not gatekeepers. Just like if you were seeing a client and the client didn't have a job, you would link them up with a vocational counselor. It's just that easy. There's a need, there's a service, you pop them in. And that's the same thing for patients who are or wanting to engage in transition. There's a need, there's a provider, you plug them in. And so for me, when people would talk to me about, saying, hey, listen, I don't feel comfortable talking to you because I don't want you to deny me services, I explain to them, like, that's unethical if I do. And that the role is to help the individual find the most comfortable place that they can be at. And that's what we focus on. So also I ask my patients to read the WPATH standards of care as well, because like when they read it, like, we're not gatekeepers. We're really not gatekeepers. There are ways that people can get around us if they want surgeries. So, but within that though, unfortunately, I've worked with medical doctors who weren't very sensitive or knowledgeable about trans related services as well. So I will do, like, that's why when I worked at the hospital, I would do ongoing education and training about that. But so I tried really hard to remove that role of a gatekeeper and instead being like, hey, listen, I'm a passenger in your car and we're driving towards your goal. And if you're telling me you want to go this way, we're going to look and see what the services are to get there.
What are the barriers and misconceptions that you've encountered with doctors and medical professionals that made you start doing this training for medical providers? Or like, what do you address in those trainings?
And so that's a great question. So what I loved about working at Westchester was that we had people from all over the world. And I was being open about my own like spirituality as a Christian, but I had several other doctors I worked with who had very strong religious beliefs. Some identified as Christian, Catholic, Muslim, Hindi. And within that, I did work with a lot of doctors who just felt uncomfortable because they were feeling that working with trans people was counter their spirituality. So when I would work with them on that, I would say like, all right, let's back up. What is your role with the individual? Specifically, what does your job expect you to do? And then how does that connect them with the individuals finding themselves? And what then is your role? So having to help people like manage, like we're all allowed our own belief system, but manage our own thoughts and feelings to once again get out of our own way. So I've worked with some doctors who would just say like, this doesn't make any sense, the person's, and they would just use like the person's gender, which is assigned at birth, and they would be inflexible to that. And I'd have to have discussions like, listen, you want this person to listen to you when you prescribe something for treatment. Do you want them to listen to you? Yes, I expect them to listen to me. I'm the doctor. Great. The words that you're using are making it absolutely 100% unlikely that they're going to listen to you. Do you want to try to argue with them about this, or do you want them to adhere to treatment? What's more important? So what I love about DBT, it's about being effective. And like the good news is the vast majority of doctors I work with didn't experience that. I would say like just 10%. But even with that though, just working on having people reconceptualize what it means to connect with people. What does it mean to actually have people follow up with treatment? How can we use appropriate wording? I love motivational interviewing. So like just using the ORS skills, making people feel wanted. Like if you're a doctor, helping someone be healthy, there's nothing better than that. And so, well, that's at least what I think, but I can't impose my values on other people. The vast majority of people I've worked with, though, they did feel that. And so for other people, they felt conflicted because of their own belief system. And when we ask people to assess their belief system and identify what their role of not the role of their beliefs, but would their beliefs ever be okay with denying people treatment? The answer is no. So me as a Christian, people will be like, you're a Christian. How can you work with someone who's gay or lesbian or bisexual? Like, and I would say, number one, it's not my job to tell them who to love. And I haven't walked one step in their shoes ever. I cannot tell anyone what to think, what to feel. And like for the way I conceptualize my belief system, not providing support and not being there to help the individual follow up their goals would be the antithesis of my belief system. So that's the way it makes sense to me. But having help individuals like refocusing on that, that's what I've had to do.
Well, I think I kind of want to switch gears because we're running short on time. So I wanted to get to some of the other topics that we wanted to talk about, but thank you for going into so much depth about trans mental health counseling.
Oh, my pleasure. I could talk about that stuff forever. I promise you.
But you did just publish a textbook on co-occurring disorders. So I assume you have something to say about that too. What can you just kind of give a summary of what are the important points to understand about co-occurring disorders within mental health counseling?
Yeah, absolutely. So like I don't know how you do it in Iowa, in New York, and in Connecticut. We have a licensed mental health counselor in New York. In New York, we don't have a licensed substance abuse counselor. We only have a certified substance abuse counselor. So we have a certified alcohol and substance abuse counselor, a KSAC. So to be a KSAC in New York, technically you only need a high school or GED diploma. So in the state of Connecticut, we have a licensed professional counselor. They do have a license as an alcohol and drug counselor, but they also have a certification. And once again, for the certification, you really only need like a high school diploma. And what we would find, and I'm not trying to, please forgive me, I'm not trying to downgrade the work or denigrate the work that substance use counselors do by any means. But what we found is traditionally, treatment of substance use and mental health has been split. So if someone was living with co-occurring disorders such as PTSD and cocaine or opiate use disorder, they would often say, listen, before you work on your PTSD, you got to get clean and sober. But the individual couldn't get clean and sober because substance use was their primary way of managing PTSD. So what we have are tons of people who are failing out of treatment. I don't even like that word. Tons of people don't follow up with treatment because treatment isn't connecting with them. And then in addition, like as we're talking about long waiting lists, it's usually easier to get into an outpatient substance use program. But then you have substance use counselors who are working with people who have co-occurring disorders, and they try to link the individual up to the mental health clinic, and they have like a 3-month waiting list. So therefore, the substance use clinician becomes the de facto mental health counselor. And even though they're not supposed to operate within that realm, they still have to try to keep an eye on these symptoms. And on the flip side, when I worked in primary mental health, when I worked with people who didn't have any education or training about substance use, their conceptualization of substance use was entirely off. So if a client said, hey, listen, my drug of choice was cocaine, but I haven't had cocaine in 2 years, but I'm drinking alcohol all the time. I've had mental health counselors be like, yeah, it's just a couple of beers. It's not a problem. I'm like, it's just a couple of beers. It's not a problem. Like, and I respect there's different ways to approach substance use, harm reduction. Like I respect that, but they didn't conceptualize how this was a difficult thing, and they didn't even know how to approach it. And so the purpose of the book is to like support both mental health counselors and substance use counselors. So we have like our first section where we talk about different mental health diagnoses and how that interacts with substance use. Our second section is in regards to special populations. So ADHD, I have a chapter on LGBTQIA. And then the third section is about evidence-based treatments, where we really jump in and show how to use CBT and other aspects. So what made me so passionate about this was that a lot of substance use professionals needed support when they couldn't ship someone to a treatment program. And a lot of mental health counselors, in their best attempts to help, though, were missing some really key aspects. And within that, most importantly, our approach is a trauma-informed approach. When we conceptualize the treatment of co-occurring disorders, we want to make sure that we're trauma-informed, being fully aware of how trauma and also like social and cultural experiences, housing insecurity, food insecurity, the experiences of marginalized populations, how that all plays in, especially when the vast majority of counselors are like white women. I'm not trying to bash white people. I'm not trying to bash women by any means, but as we don't have, we're doing a much better job of becoming more diverse, but we didn't necessarily always represent the people who are seeking treatment. So we're improving on that, but I really wanted to make sure that in this text, we tackle those things head on to provide the best way of navigating some of these barriers to treatment.
I hear commitment to diversity and all of that, not to go away from the co-occurring disorders discussion, but that made me curious. Are there any initiatives that IMHCA is taking on to promote diversity, equity, inclusion within the counseling profession?
Absolutely, yeah. So our current president, Dr. Beverly Smith, she's been doing an excellent job. So we had our IMHCA Fall Summit, which was primarily DEI, diversity, equity, inclusion. And we also, we have a subcommittee for diversity, equity, and inclusion. Then in addition to that, what I'm trying to do, like, so when you're the president, I just can't be like, we're going to do this and everything's going to be great. But what I really want to do, and I'm hoping we can do this, is I would like to have like 2 live like CEU presentations per month for a year. And one of them, one of the presentations would be related to our subset areas of mental health. So it could be co-occurring disorders, it could be working with adolescents, it could be LGBT plus. But then I also wanted 1 presentation a month specifically on diversity, equity, and inclusion, working with marginalized populations, how we can support even marginalized clinicians. One of the things I do is I will go into community agencies and I will actually provide trainings as to how white counselors can support non-white counselors, especially if we're working with racist clients. So talk about like how to have like difficult discussions, but also how to be able to come to a place where people feel supported and feel safe, especially at work.
Great. And I know some people would say they don't just want to hear 2 straight white guys talking about diversity, and I'm wondering if you could identify any people who represent these populations that such as trans or LGBT or different racial dynamics that come about, or ethnic dynamics that come about within counseling. Do you have any specific trainers or authors that you would recommend, or that you that have been influential for you?
You know, I appreciate you saying that. So like a woman I went to school with, her name is Dr. Danita Thompson, and African-American woman. She has been so wonderful and amazing, especially with having these discussions. And during COVID, she has her own, she doesn't have her own private practice. She has her own clinic in New Jersey. And she will do, it's called baggage claim, where she'll have like ongoing discussions. I don't know if it's weekly or bi-weekly, but specifically about like racial issues and relationship to mental health. So I've leaned on her. She's like a very good friend of mine. And what I appreciate is like for her and her community, she's actually been invited to speak and work with the police and justice linked organizations as to how to like approach marginalized populations, and also how to prevent instances where like abuse of power happen. Now, there's other people and other people's names I want to throw out, but I don't want to throw out their names because I haven't gotten approval from them for them to actually do stuff. So I don't want to throw them under the bus. But Danita Thompson, I've already like relied on her. I've already done great work with her. So I'm going to continue to use her as well. But she's been absolutely great.
Okay, Danita Thompson. Okay, great. Sounds good. Before we wrap up, I did want to talk a little bit about telehealth, just because we put it as a point to talk about. So I feel like we've become pretty accustomed to telehealth and providing telehealth services at this point. It's been a couple of years now that most people have been involved in it somehow. And from what I gather, you're interested in best practices and ethical issues around telehealth. And I'm wondering, what are some things we're missing?
Yeah, it's a great question. And like when COVID happened, I really have to give everyone props for the people on the front lines who had to switch. So back in 2015, one of my mentors, Dr. Deborah Legge, she had the DCC, the Distance Credentialed Counselor certification, which eventually became the board certified telemental health provider. And I got the DCC, and then I got the board certified telemental health provider, which was some additional training. It's about 40 hours altogether. And you could do that through the Center for Credentialing and Education. So that is a formal credential. So within that, I got that like several years ago. And there are some basics which they review in the very beginning that when I was talking to counselors who were doing telehealth, they never knew, such as every time you talk to someone on telehealth, whether it be on the phone or some kind of like face-to-face software, you need, before the session even starts, to write down the location of where the client's at. Imagine if the client says, oh, I want to kill myself, and you never ask them where they're at, and they say, well, I'm not going to tell you. That's totally different. You're screwed. So basic stuff like that. And then also, like, I know it sounds ridiculous, but having the client provide affirmation that it's them if you're doing a telephone session. Like, all right, can you tell me your date of birth? It's last four of your social, just random stuff like that. And so you would know it, so you could identify someone's identity, because technically if we're talking to the wrong person, we're breaking confidentiality. And I'm so sorry to laugh at this stuff, but as COVID happened and I worked with people who were doing telehealth, they would tell me, you know, yeah, like I was talking to a client, but you know, I was talking to them while I was doing some dishes and I went out to the store. I'm like, all right, so you're going to have to do a non-billable session for that, because we are not allowed to do anything else when we're doing telehealth except sit there and talk to the client, even if we're on the phone. We have to treat every telehealth session like it's a real life face-to-face session. And then, you know, just talking about ways to like navigate, like if a client is distracted, that does happen, how through substance use, how we can evaluate if someone has potentially resumed substance use. Those things are there too, but just as ridiculous as it is affirming someone's identity and knowing where they're at, and also knowing like the closest agencies to them are key, just absolutely key.
Are there any guidelines or resources or places to go to learn about best practices and telehealth? Any articles or that you would recommend?
Yeah, like I would, and I'm so sorry. Like I hate to. I'm so sorry. I don't want to I don't want to recommend a product because I'm not interested in making that product money. But I'm going to recommend a product because this is what I used for myself, and that was the board certified telemental health certification from the Center for Credentialing and Education. And they give you a few different options that you choose to meet the criteria for that. So they have a few different companies that do training programs. So I'm not going to tell you which one to go through, but that, like, what I really like about that, it covers everything. It covers software, it covers like how to manage a breach. It goes into so much detail about stuff I never conceptualized. And especially if you're in a private practice, it's perfect. So I encourage people to check out the board certified telemental health provider from the Center for Credentialing and Education.
Great, thank you. I appreciate that. And we won't fault you for recommending a product. I know you have to be careful about that kind of stuff, but
I'm not getting paid to recommend it. I'm not a representative of theirs by any means, but I'm so thankful for that training. And especially when COVID happened, I cannot thank God enough, just having all that information, because when COVID hit, we were so overwhelmed that we didn't know how to adjust. So that certification, especially as we go forward, because telehealth isn't going away, I just encourage people to get it.
We're at time right now, so I just wanted to, I want to respect your time, but I wanted to know if there's anything else that you wanted to speak to or bring up to round out this conversation.
Yeah, I'll do my best to make this really short and sweet. But I'd like to say this whenever I have the luxury of speaking with someone or speaking with a group of people, because I don't mean to be hammy or corny, but the words, when I say these words, I 100% sincerely mean them. So Sean, as you're working on getting your master's degree, for you, your fellow students, all the people who are working towards becoming counselors, all the counselors that are currently working, regardless of what area they're working in, there's never been such a need as there is right now. And I cannot thank every counselor, every clinician, every advocate, every person who's on the front lines trying to make the world a better place enough, because the services that we provide, I promise you, are equally as important as any other medical service. We keep people alive. Neurosurgeons keep people alive. The work we do is equally as important as any medical service. What we do matters. We do save lives. So I want to thank you. I want to thank IMHCA. You're doing absolutely amazing, wonderful work. And just to remind everyone that even when you get burnt out, even when you feel hopeless and feel like it's not working, not only is it not working, but you're working, and you're the best thing you could bring your patient. So please, people, just don't give up. We're in the most difficult time, but we are making it better.
Well, thank you, Fred. And I don't think you handed up too much there, but I appreciate that. And I think our listeners do too. So I just want to say I appreciate you coming in and talking to us out here in flyover country, and recognizing that we exist here in the middle of the country, and reaching out to reaching out to us as a national organization. We really appreciate that.
My pleasure. And if you ever need anything, feel free to reach out. And I just appreciate you guys. So I'm just always available. Feel free.
Okay. Well, thank you. And we'll let you go now.
All right. Thank you. Take it easy. Have a good one. We'll see you.